Good morning, ladies and gentlemen. My name is Iksung from Severance Hospital. Excuse me. It's a great privilege for me having presentation in this wonderful conference. I'm going to talk about the aortic valve imaging and specimen while we consider in TAVR. But for the specimen lecture, at end of this session, we'll see the actual specimen around in this room. So I'm going to explain the aortic valve imaging for TAVR. If someone asks us to that which structure will be most important structure for TAVR planning, I would say aortic annulus. The reason is that at first, actually aortic annulus is the structure that TAVR valve is going to be actually anchored. And the other important reason is that this annulus plane is going to be served as the standard of the all other measurements. So we're going to measure sinus of Valsalva, also the sinotubular junction, LVOT, which is very parallel to the annulus plane. So if the annulus plane is distorted, every measurement would go wrong. So most important step for TAVR measurement is finding true annulus. So what is the annulus? Annulus is a virtual ring which was formed by joining basal attachments of the aortic valve leaflets, cusps. So this is a virtual plane which is not actually exist. So if we connect the lowest point, the hinge point of each cusp, that's going to be the annulus. So in this diagram, we can see what plane is aortic annulus. So RCC, the hinge point, NCC, LCC hinge point. If we connect these three, that's going to be the annulus plane. So how can we find this annulus plane in cardiac CT, which is, if we have a 3-mensio, some kind of dedicated program, it is kind of easy. So this red line is this, and this is left coronary cusp. I try to find the lowest, the hinge point of the LCC. Now the NCC hinge point here, and go there and find the RCC and hinge point here. And this program automatically find the annulus plane which is very easy. But if we don't have this program, we try to find this by ourselves. So it's kind of hard because it's a kind of 3-body problem. If we change one plan, then the other plan can be distorted. So one of the ways, try to find the two, for instance, an NCC and LCC plan first, then don't change this plan and find that the other plan. That's gonna be way to how to find this annulus plan. So if we find annulus plan, what we are doing is sizing annulus. As we can see here, annulus is not always a circular structure. It could be very oval shape, but what we are doing is try to draw circular as possible, because that's gonna be actually the valve is gonna be implanted. So this will be the annulus measurement. We usually provide parameter, shortest diameter, longest diameter, and area. And the parameter is going to be served for the self-expandable valve, and the area is usually served for balloon expandable valves. So what we have to provide is these all values, so that the interventionist actually consider this as for their TAVI procedure. Of course, we can do this measurement with transesophageal echocardiography. In TEE, actually, the step is exact same. What I'm trying to do is try to hinge point of each cusp. When we connect this 3 hinge point, that's going to be served as an annulus plane, and we can get all those CT values in echo as well. But we have to consider is that in inner diameter measurement using echo is usually smaller than cardiac CT, but almost all the reference values of the TAVR procedure is provided using cardiac CT. So when we do echo measurement, we have to think about a little bit oversizing, and that's kind of a natural. That's because the echo, the spatial resolution is not really good. So the inner diameter, if two lines are blurred, if we measure inner to inner diameter, that's going to be underestimate the actual size of the actual structure. So that's what we have to consider when we do the TEE measurement. Next thing what we have to do is LVOT measurement. In TAVR procedure, we usually 3 to 4 millimeter lower from the annulus plane. That's going to be the LVOT measurement. So the measurement is usually same. We also provide all those perimeter area and also the shortest and longest diameter in cardiac CT measurement. So what we have to do is we have to compare the value of the annulus and LVOT. So if LVOT is very smaller than annulus, we have to think about the LVOT annular rupture risk. Also, what we have to see is the calcification around here, and I'm going to touch the calcification thing later. Next thing what we have to measure is sinotubular junction. Sinotubular junction is usually the narrowest part of the aortic valve. So we usually provide also those values, and we have to compare these values with the annulus, LVOT, and sinotubular junction diameter. If we try to balloon too large, if this STJ is small, there could be a rupture risk. So we have to consider this. The other important thing we have to consider is coronary height. So this is now I'm trying to measure the left coronary cusp height. So the height measurement from the annulus plane. So annulus plane is very important. So if the left or right coronary cusp height is less than usually 1 centimeter, that would be the risk of the coronary obstruction. But we have to think about the sinus of Valsalva size and sinus of Valsalva height together. Even though the coronary height is low, if the sinus Valsalva diameter is enough, we can expect the coronary obstruction risk could be lower. But if the sinus Valsalva diameter is small and the coronary height is less than 10 millimeter, we can expect that there could be a really high risk of the coronary obstruction. Also, the most important thing for the TAVR measurement in aortic annulus and aortic valve is calcification. Calcification is actually the structure that TAVR can be possible because it could be the anchor site for the valve, but also the most of the TAVR complication was originate from calcification. Usually, leaflet calcification is related to coronary obstruction, and annular calcification could be related to the annular rupture risk or the conduction abnormality. So we have to evaluate where the calcium is and the amount of the calcium, but we can use. When we use MIP image, we can see maximum intensity projection is MIP. We can see the calcification of the annulus and or the structure at one view. Also, this kind of hockey puck view is also easy to visualize the calcification. So we usually provide the hockey puck view and this MIP image together to provide the calcification information for the intervention cardiologist. This is one of the example we have. The calcification makes a complication. This case we performed in 2019 in early period. We did a pre-ballooning and we implanted the CPM valve. Can you find any complication after this result? I think some of you may notice that there is a extravasation of contrast to this site. Let me magnify this. You can appreciate that there is extravasation of the contrast. So this is annular rupture, maybe contained rupture. The patient was stable, and when we do TT in short axis view, we can see that on the left coronary cusp side, there is a pseudoaneurysm structure, and the flow is go in and out. So this is an annular rupture contained. So why this happen? This is a post-TAVR CT to evaluate this. In CT, we can also appreciate that there is a annular contained rupture here, and this is just beneath the left coronary artery. But it's not. There is no pericardial effusion or the other abnormalities. So this is contained annular rupture. Why this happen? There are a lot of reasons why there is an annular rupture, risk factors, and one of them is subannular calcification, and also the depth of the calcification within LVOT. So in one of the example to grading the valve calcification is a severe category, means that if the calcification extended into the LVOT, we should consider this severe calcification. So let me compare this image with the pre-TAVR CT. When we see the pre-TAVR CT, this is the MPR image of that calcification. There we can appreciate that LVOT calcification is here, and the annular calcification extended to the LVOT, and that is the exact site of where the annular rupture is. So what we have to think about pre-procedurally is that consider this calcification, where the calcification is. If the calcification extended into the LVOT, we have to consider annular rupture. So there could be a controversy, but I would use self-expander valve for this case to reduce this kind of annular rupture. Last thing what we are providing is the three-cusp view. This is an implantation angle. So this implantation angle is, we are using CT, we try to find the angle that NCC is the lowest and RCC and LCC is the highest. This angle is, we can align all three cusps in one view, so it will be served as most of the TAVR implantation. But if we want to implant a balloon expandable valve, such as Evolut, we may also provide the cusp overlap view. NCC is the lowest, and the other cusps are overlapped. If we want to implant the valve really shallow implantation, we can also provide this cusp overlap view as well. For the conduction abnormality, even though the permanent pacemaker implantation after TAVR is decreasing, still around 10% of the rate of the permanent pacemaker implantation after TAVR. So this is one of the things that we have to overcome. So why this kind of conduction abnormality happened after TAVR? This originates from the anatomic structure. There is a membranous septum here. It's located between NCC and RCC, and the lowest part of the membranous septum serves as the APCIS site of the His bundle. So if the TAVR valve implanted in here, if the valve direct compressed the membranous septum and the APCIS site, we can make a left bundle branch block or complete AV block. Even though there is no direct compression, if there is a hemorrhage or hematoma, that could also cause conduction abnormality, and also ischemic injury or inflammation. All these can make a conduction abnormality. So what we can think about is if the membranous septum is very short, there will be higher risk of the interference of this conduction pathway. So we can measure this membranous septal length in cardiac CT. There will be two ways. One of the way is because we find this annulus plan. So this is the standard. So we measure the depth of the length of the membranous septum using cardiac CT, and if it's less than 3 millimeter, there will be a higher risk of the pacemaker implantation. If more than 6 millimeter, there will be very less risk of the pacemaker implantation. The other way would be using coronary, just coronal view, and using this, usually 6 millimeter cutoff is used. So usually coronal view is longer, subannular is kind of lesser than this value. So if we can implant, if the membranous septal length is less than 2 and the coronal view is less than 6, there will be a high risk of the coronary obstruction, the conduction abnormality. And bicuspid aortic valve usually have a lower, the lesser MS length, so that could be one of the reasons why implant more pacemaker. If we know this implantation, if we know the patient has very short membranous septum, if we try to implant depth less than this membranous septum, actually we can decrease those implantation risks. So this could be one of the way we can use for the reduce the pacemaker implantation. So in summary, annulus sizing is very important. From that, we can measure LVOT and the other parameters. Calcification is most important thing to reduce calcification, and also to reduce conduction abnormality. We might use membranous septal length as a guide. Thank you so much for your attention.